1. What is ischemic heart disease, IHD? Group of syndromes related to myocardial ischemia. 2. What is the leading cause of death in the U.S.? Ischemic heart disease, IHD. 3. What is stable angina due to? Atherosclerosis of coronary arteries with greater than 70% stenosis. 4. What is unstable angina? Chest pain that occurs at rest. 1. What is stable angina relieved by? Rest or nitroglycerin. 2. What are the risk factors for IHD? They are similar to those of atherosclerosis, incidence increases with age. 3. What does unstable angina represent? Reversible injury to myocytes, no necrosis. 4. What does the EKG show in unstable angina? Saint segment depression due to subendocardial ischemia. 1. What does stable angina represent? Reversible injury to myocytes, no necrosis. 2. What is prinzmetal angina? Episodic chest pain unrelated to exertion. 3. What is prinzmetal angina due to? Coronary artery vasospasm. 4. What does prinzmetal angina represent? Reversible injury to myocytes, no necrosis. 1. What is stable angina? Chest pain that arises with exertion or emotional stress. 2. What does the EKG show in stable angina? Saint segment depression due to subendocardial ischemia. 3. What is unstable angina relieved by? Nitroglycerin. 4. In unstable angina there is a high risk of what? Progression to myocardial infarction. 1. What does the EKG for prinzmetal angina show? Saint segment elevation due to transmural ischemia. 2. What is prinzmetal angina relieved by? Nitroglycerin or calcium channel blockers. 3. What is myocardial infarction? Necrosis of cardiac myocytes. 4. What is the second most commonly involved artery in ME? RCA, right coronary artery. 1. What does the EKG show in transmural infarction? Saint segment elevation. 2. What do the laboratory tests detect for myocardial infarction? Elevated cardiac enzymes. 3. What is the most sensitive and specific marker, gold standard, for ML? Troponin I. 4. What are the troponin I levels after 2 to 4 hours? Levels rise 2 to 4 hours after infarction. 1. When do troponin I levels peak? At 24 hours. 2. When do troponin I levels return to normal? By 7 to 10 days. 3. What is CKMB is useful for? Detecting reinfarction that occurs days after an initial ME. 4. When do creatine kinase MB, CKMB, levels rise? 4 to 6 hours after infarction. 1. When does creatinine kinase MB levels peak? They peak at 24 hours. 2. When does creatinine kinase MB levels return to normal? By 72 hours. 3. How does aspirin and/or heparin help treat ME? Limits thrombosis. 4. How does supplemental O2 help treat ME? Minimizes ischemia. 1. How do nitrates help treat ME? Vasodilate coronary arteries. 2. How does beta blockers help treat ME? Slows heart rate, decreasing O2 demand and risk to arrhythmia. 3. How does ACE inhibitors help treat ME? Decreases LV dilation. 4. How does fibrinolysis or angioplasty help treat ME? Opens blocked vessel. 1. What does fibrinous pericarditis present as? Chest pain with friction rub. 2. What does rupture of ventricular free wall lead to? Cardiac tamponade. 3. What does rupture of interventricular septum lead to? Shunt. 4. What does rupture of papillary muscle lead to? Mitral insufficiency. One. What is sudden cardiac death usually due to? Fatal ventricular arrhythmia. 2. What does chronic ischemic heart disease progress to? Congestive heart failure, CHF. 3. What is congestive heart failure? Pump failure, divided into right and left-sided failure. 4. What is the main treatment for left-sided heart failure? Treatment is ACE inhibitor. 1. What is right-sided heart failure most commonly due to? Left-sided heart failure. 2. What are the congenital heart defects? Arise during embryogenesis. 3. When do congenital heart defects usually arise? Usually weeks 3 through 8. 4. Most congenital heart defects are sporadic. One. What do defects with right to left shunting usually present as? Cyanosis shortly after birth. 2. What is ventricular septal defect, VSD? Defect in the septum that divides the right and left ventricles. 3. What is the most common congenital heart defect? Ventricular septal defect, VSD. 4. What is ventricular septal defect, VSD, associated with? Fetal alcohol syndrome. 1. What does ventricular septal defect, VSD, result in? Left to right shunt. 2. What is atrial septal defect? Defect in the septum that divides right and left atria. 3. What is the most common type of atrial septal defect? It is ostium secundum, 90% of cases. 4. What does atrial septal defect result in? Left to right shunt and split S2 on auscultation. 1. What is patent ductus arteriosus? Failure of ductus arteriosus to close. 2. What is patent ductus arteriosus associated with? Congenital rubella. 3. What does patent ductus arteriosus result in? Left to right shunt between the aorta and the pulmonary artery. 4. What is the effect of PGE on patent ductus arteriosus? PGE maintains patency of the ductus arteriosus. 1. What is seen on X-ray in tetralogy of Fallot? Boot-shaped heart on X-ray. 2. What does truncus arteriosus present with? Early cyanosis. 3. What is coarctation of the aorta? Narrowing of the aorta. 4. What is coarctation of the aorta classically divided into? Infantile and adult forms. 1. What is the purpose of heart valves? To prevent backflow. 2. What are the Has4 valves of the heart? Tricuspid, pulmonary, mitral, and aortic. 3. What is pancarditis? A. Endocarditis B, myocarditis C, pericarditis. 4. What is pericarditis in pancarditis lead to? Friction rub and chest pain. 1. What does chronic rheumatic heart disease result in? Stenosis with a classic fish mouth appearance. 2. What is aortic stenosis? Narrowing of the aortic valve orifice. 3. What is aortic stenosis usually due to? Fibrosis and calcification from wear and tear. 4. When does aortic stenosis present? In late adulthood, greater than 60 years. 1. In aortic stenosis, what does treatment involve? Valve replacement after onset of complications. 2. What is the treatment for aortic regurgitation? Valve replacement once LV dysfunction develops. 3. What happens in mitral valve prolapse? Ballooning of mitral valve into left atrium during systole. 4. What is the incidence of mitral valve prolapse in U.S. adults? Seen in 2–3% of U.S. adults. 1. What is the etiology for mitral valve prolapse? Unknown. 2. What might mitral valve prolapse be seen in? Marfan syndrome or Ehlers-Danlos syndrome. 3. What is the treatment for mitral valve prolapse? Valve replacement. 4. What does mitral regurgitation result in? Volume overload and left-sided heart failure. One. What is mitral stenosis? Narrowing of the mitral valve orifice. 2. What is mitral stenosis usually due to? Chronic rheumatic valve disease. 3. What is endocarditis usually due to? Bacterial infection. 4. What is the most common overall cause of endocarditis? Streptococcus viridans. One. What is the fever in bacterial endocarditis due to? Bacteremia. 2. What is the murmur in bacterial endocarditis due to? Vegetations on heart valve. 3. What are Janeway lesions? Erythematous non-tender lesions on palms and soles. 4. What are osier nodes? Tender lesions on fingers or toes. 1. What is anemia of chronic disease due to? Chronic inflammation. 2. What is dilated cardiomyopathy? Dilation of all four chambers of the heart. 3. What is the most common form of cardiomyopathy? Dilated cardiomyopathy. 4. What does dilated cardiomyopathy result in? Results in systolic dysfunction, ventricles cannot pump. One. What is the treatment for dilated cardiomyopathy? Heart transplant. 2. What is hypertrophic cardiomyopathy? Massive hypertrophy of the left ventricle. 3. What does restrictive cardiomyopathy present as? Congestive heart failure. 4. What are the cardiac tumors? Myxoma, rhabdomyoma. One. What is the most common primary cardiac tumor in adults? Myxoma. 2. What does myxoma usually form? A pedunculated mass in the left atrium. 3. What is rhabdomyoma? Benign hematoma of cardiac muscle. 4. What is the most common primary cardiac tumor in children? Rhabdomyoma. One. What is rhabdomyoma associated with? Tuberous sclerosis. 2. Where does rhabdomyoma usually arise? In the ventricle. 3. Which type of tumors are more common in the heart? Metastatic tumors more than primary tumors. 4. What does common metastases to the heart include? Breast and lung carcinoma, melanoma, and lymphoma. One. What does occlusion of the left circumflex artery lead to? Infarction of lateral wall of the LV. 2. What does the EKG show for the initial phase of infarction? Subendothelial infarction, St. segment depression. 3. What are the less common causes for sudden cardiac death? Mitral valve prolapse, cardiomyopathy, and cocaine abuse. 4. In left-sided heart failure, what does pulmonary congestion lead to? Pulmonary edema. 1. In tetralogy of Fallot, what does the right-to-left shunt lead to? Early cyanosis. 2. In tetralogy of Fallot, what patient behavior is observed? They learn to squat in response to a cyanotic spell. 3. What is the transposition of the great vessels associated with maternal diabetes? 4. What does transposition of the great vessels presents with early cyanosis? Pulmonary and systemic circuits do not mix. One. What is diagnosis of acute rheumatic fever based on Jones criteria? 2. What is the minor Jones criteria? Minor criteria are nonspecific and include fever and elevated ESR. 3. In endocarditis, which valve is involved more commonly? Mitral valve is involved more commonly than the aortic valve. 4. How is endocarditis characterized? By small vegetations along lines of closure that lead to regurgitation. One. What is the most common cause of death during the acute phase? Myocarditis. 2. What is chronic rheumatic heart disease? Valve scarring that arises as a consequence of rheumatic fever. 3. What does chronic rheumatic heart disease almost always involve? The mitral valve. 4. What does chronic rheumatic heart disease occasionally involve? The aortic valve. One. What do complications in chronic rheumatic heart disease include? Infectious endocarditis. 2. What does a bicuspid aortic valve increase the risk for? Aortic stenosis and hastens disease onset. 3. How many cusps does a normal aortic valve have? 3 cusps. 4. What is the effect of fewer cusps on the aortic valve? It results in increased wear and tear on each cusp. One. What is aortic regurgitation? Backflow of blood from the aorta into the left ventricle during diastole. 2. What is the most common cause of aortic regurgitation? Isolated root dilation. 3. What is pulse pressure? It is the difference between systolic and diastolic pressures. 4. What does aortic regurgitation result in? LV dilation and eccentric hypertrophy, due to volume overload. One. What is mitral regurgitation? Reflux of blood from the left ventricle into the left atrium during systole. 2. Mitral regurgitation usually arises as a complication of what? Mitral valve prolapse. 3. What are the clinical features for mitral regurgitation? 1. Holosystolic, blowing, murmur. 4. What is Staphylococcus aureus? High virulence organism that infects normal valves, most commonly the tricuspid. One. What does Staphylococcus aureus result in? Large vegetations that destroy the valve, acute endocarditis. 2. What is Staphylococcus epidermidis associated with? Endocarditis of prosthetic valves. 3. What is Streptococcus bovis associated with? Endocarditis in patients with underlying colorectal carcinoma. 4. What are HACEK organisms associated with? Are associated with endocarditis with negative blood cultures. One. HACEK. Haemophilus, actinobaceous, cardiobacterium, Eichneller, Kingella. 2. What is the transesophageal echocardiogram useful for? Detecting lesions on valves. 3. What is cardiomyopathy? Group of myocardial diseases that result in cardiac dysfunction. 4. What are the complications of dilated cardiomyopathy? Mitral and tricuspid valve regurgitation and arrhythmia. One. What is the most common cause of dilated cardiomyopathy? It's idiopathic. 2. In hypertrophic cardiomyopathy, what does biopsy show? Myofiber hypertrophy with disarray. 3. What is Liebman-Sachs endocarditis due to? Sterile vegetations that arise in association with SLE. 4. What does Streptococcus viridans result in? Small vegetations that do not destroy the valve, subacute endocarditis. One. What is endocarditis? Inflammation of endocardium that lines the surface of cardiac valves. 2. With mitral valve prolapse, when does the mid-systolic click get louder? Click and murmur become louder with squatting. 3. What artery is most commonly involved? Artery in me. LAD, left anterior descending artery. 45% of cases. 4. What are the complications for 1 to 3 days from time of infarction? Fibrinous pericarditis presents as chest pain with friction rub. 1. What are the clinical features for left-sided heart failure due to? Decreased forward perfusion and pulmonary congestion. 2. In left-sided heart failure, why is there paroxysmal nocturnal dyspnea? It's due to increased venous return when lying flat. 3. In left-sided heart failure, pulmonary edema results in what? Dyspnea, paroxysmal nocturnal dyspnea, orthopnea, and crackles. 4. How can left-sided heart failure lead to intra-alveolar hemorrhage? Small, congested capillaries may burst, leading to intra-alveolar hemorrhage. 1. In left-sided heart failure, what is intra-alveolar hemorrhage marked by? Hemosiderin-laden macrophages, heart failure cells. 2. What are the clinical features for right-sided heart failure due to? Congestion. 3. In right-sided heart failure, what is the dependent pitting edema due to? Increased hydrostatic pressure. 4. In what percentage of live births do you see congenital heart defects? Seen in 1% of live births. One. Congenital heart defects often result in shunting between left systemic and right pulmonary circulations. 2. Defects with left to right shunting may be relatively asymptomatic at birth, but the shunt can eventually reverse. 3. What does increased flow through the pulmonary circulation result in? Hypertrophy of pulmonary vessels and pulmonary hypertension. 4. What does increased pulmonary resistance eventually result in? Reversal of shunt. 1. What happens with small defects in ventricular septal defect (VSD)? They are often asymptomatic. 2. What happens with large defects in ventricular septal defect (VSD)? Can lead to Eisenmenger syndrome. 3. What is the treatment for ventricular septal defect (VSD)? Involves surgical closure. Small defects may close spontaneously. 4. What type of atrial septal defect is associated with Down syndrome? Ostium primum. 1. Why is there split S2 on auscultation in atrial septal defect? Increased blood in right heart delays closure of pulmonary valve. 2. What is an important complication of atrial septal defect? Paradoxical emboli. 3. What does the treatment for patent ductus arteriosus involve? Indomethacin, which decreases PGE2 resulting in PDA closure. 4. In tetralogy of fallot, what determines the extent of shunting and cyanosis? The degree of stenosis. 1. What is tricuspid atresia? Tricuspid valve orifice fails to develop, right ventricle is hypoplastic. 2. What is tricuspid atresia often associated with? ASD, resulting in a right-to-left shunt, presence with early cyanosis. 3. What is the infantile form of coarctation of the aorta associated with? A PDA. 4. What does the infantile form of the coarctation of the aorta present as? Lower extremity cyanosis in infants, often at birth. 1. What is the infantile form of coarctation of the aorta associated with? Turner syndrome. 2. What is the adult form of coarctation of the aorta associated with? It's not associated with a PDA. 3. Where is the coarctation for the adult form of coarctation of the aorta? Coarctation lies after, distal to, the aortic arch. 4. What is the adult form of coarctation of the aorta associated with? Bicuspid aortic valve. 1. What does valvular lesions generally result in? Stenosis, decreased caliber of the valve orifice, or regurgitation, backflow. 2. What is sydenham chorea in the major criteria of Jones criteria? It is rapid, involuntary muscle movements. 3. What usually happens to an acute attack of rheumatic fever? Usually resolves, but may progress to chronic rheumatic heart disease. 4. What is the classic finding in restrictive cardiomyopathy? Low voltage EKG with diminished QRS amplitude. 1. What is ischemic heart disease, IHD, usually due to? Atherosclerosis of coronary arteries, which decreases blood flow to the myocardium. 2. Why does stable angina arise with exertion? Decreased blood flow is not able to meet the metabolic demands of the myocardium during exertion. 3. What does occlusion of the left anterior descending artery, LAD, lead to? Infarction of the anterior wall and anterior septum of the LV. 1. How does stable angina present? As chest pain lasting less than 20 minutes that radiates to the left arm or jaw, diaphoresis, and shortness of breath. 2. What is unstable angina usually due to? Rupture of an atherosclerotic plaque with thrombosis and incomplete occlusion of a coronary artery. 3. What does occlusion of right coronary artery, RCA, lead to? Infarction of the posterior wall, posterior septum, and papillary muscles of the LV.